Esophageal cancer carries a very heavy global cancer burden, accounting for more than 500,000 deaths per year. The treatment of this disease still remains very suboptimal. Patients receiving first-line therapy for advanced esophageal squamous cell cancer had a median survival of around 10 months or less. So we conducted our study, which is called CheckMate 648 study, which is the largest randomized controlled trial conducted in this disease setting, where we evaluate a dual checkpoint inhibition using Ipilimumab and Nivolumab, as well as checkpoint inhibition plus chemotherapy, Nivolumab plus chemo versus chemotherapy alone in our study. So in this study, patients with unresectable metastatic squamous cell cancer of the esophagus were recruited irrespective of the tumor PD-L1 expression. Patients were untreated for advanced disease. Altogether, 970 patients were randomly allocated into 3 different treatment groups. The first group was Nivolumab plus chemotherapy. The chemotherapy used is cisplatin and 5-FU given every 4 weeks. The second experimental arm is the combination of Nivolumab plus Ipilimumab. Here, the Ipilimumab is given every 6 weeks. The third arm, which is the control arm, is chemotherapy alone using cisplatin and 5-FU given every 4 weeks. The primary endpoints of this study was using the biomarker specified tumor progression, tumor PD-L1 expression of 1% or more, and is using both overall survival and progression-free survival as the primary endpoints. The secondary endpoints included overall and progression-free survival in all randomized population, objective response rate, and safety. As we could expect in a large randomized control trial like this, the baseline characteristics of patients were well balanced across the 3 treatment arms. Just under half of our patients were PD-L1 expression positive, i.e. 1% or more, and around 70% of the patients came from the Asian countries. In our first treatment comparison, Nivolumab plus chemotherapy versus chemotherapy alone, and in our primary patient population of PD-L1 expression 1% or more, we find a highly statistically significant improvement in overall survival in favor of Nivolumab plus chemotherapy. The hazard ratio was 0.54, which is a 46% relative reduction in the risk of death in favor of Nivolumab plus chemotherapy. And this translated into more than 6 months improvement in median overall survival, and also a very significant difference in terms of 1-year overall survival rate. In the all randomized patient population, we again observed a statistically significant improvement in overall survival in favor of Nivolumab plus chemotherapy. Again, here we observe an improvement of median survival of 2.5 months. In terms of progression-free survival, we observe a statistically significant improvement of PFS in our PD-L1 positive expression patients in favor of Nivolumab plus chemo. However, in our all randomized patient population, there was a trend towards improvement, but that did not pass the statistical boundary. But what we observed in CheckMate 648 in terms of PFS, because the progression-free survival was assessed by central review, there were in fact a lot of patients who move on to subsequent treatment therapy before the CT scan showing disease progression. So as a pre-planned analysis, we also look at investigator-assessed progression-free survival. And here we observed a superior PFS in favor of Nivolumab plus chemotherapy, even in the all randomized patient population. So in our second treatment comparison, looking at a chemotherapy-free option of Ipilimumab plus Nivolumab versus chemotherapy, again in our primary patient population of PD-L1 positive expression, we observed a significant overall survival benefit in favor of Ipilimumab plus Nivolumab compared to chemotherapy alone. In our all randomized patient population, we also observed a statistically significant improvement in overall survival in favor of Ipilimumab plus Nivolumab compared to chemotherapy alone. Now, for progression-free survival, as we would expect from other randomized controlled trial for IO or checkpoint inhibitors versus chemotherapy, there was no differences in terms of PFS between the Ipilimumab plus Nivolumab compared to chemotherapy. However, there was a trend towards a better progression-free survival, especially in the latter half of the PFS curve in our PD-L1 expression positive patient population. Now, the other secondary endpoints were objective response rate. And here, in both the treatment comparisons, i.e. NIVO plus chemo versus chemotherapy alone, as well as Ipilimumab plus Nivolumab versus chemotherapy alone. Again, in our primary patient population of PD-L1 positive patients, we observed a much higher response rate in the IO containing arms compared to chemotherapy arm. The complete response rate was nearly more than 3 times higher for the Nivolumab containing arm compared to the chemotherapy alone. And for the response that was achieved by Nivolumab, either with chemotherapy or Nivolumab plus Ipilimumab, they were much more prolonged compared to the objective response that was achieved by chemotherapy alone. Lastly, for safety, what we observed across all the patients we treated across the 3 arms, the safety profiles are different between the chemotherapy containing arm compared to the IO containing or the Ipilimumab plus Nivolumab arms. But importantly, the treatment-related mortality were very low across all 3 arms and very similar across the 3 arms. So in conclusions, with the overall survival benefit seen in both our primary patient population of PD-L1 expression positive or 1% or more, as well as in all randomized patient population, that we now have 2 new potential standard of care with Nivolumab plus chemotherapy or Nivolumab plus Ipilimumab in patients with advanced esophageal squamous cell cancer, based on our CheckMate 648 study, which is the largest randomized controlled trial conducted to date in this disease setting. From this significant overall survival benefit that we've seen, we now have 2 new treatment options. So now I think when we face or when we have patients with newly diagnosed advanced esophageal squamous cell cancer, I think the decision is to give IO drug, i.e. Nivolumab in this situation, and the decision really for the clinicians is whether one should add chemotherapy to Nivolumab or whether we should add Ipilimumab to Nivolumab. One, of course, is still a chemotherapy-containing option. The second option with the Ipilimumab and Nivolumab is a chemotherapy-free options.